Hello, MedTech Insight enthusiasts. This is Dr. Jennifer Joe with my co-host, the fabulous Dr. Ami Bhatt. During each show, we talk with one or two guests about the latest in innovation in digital health, biotech, and healthcare, with a focus on clinicians who are looking at innovation and are game changers in the field. Dr. Bhatt is a cardiologist who built the Massachusetts General Hospital telecardiology program, and most recently, not that recent though, has been named the Chief Innovation Officer of the American College of Cardiology. Big congratulations. Still looking forward to hearing what you're doing there. Dr. Bhatt and I co-authored the 2021 Springer Healthcare Information Technology for Cardiovascular Medicine, Telemedicine and Digital Health textbook. Be sure to check it out. So if you're looking for that, you can find it there. When I'm not hosting the show, I see patients in the VA emergency room, urgent care, and hospice setting. MedTech Insights is a live weekly interactive talk show, and we love interacting with our audience. Please be sure to post your comments and questions for us in our social feed, LinkedIn, YouTube, and Facebook, and we'll incorporate them into our show. We'd love to know who you are, where you're watching from, and what you're working on. All shows are recorded and available after the fact on our website, Vanguard.Health /MedTech Insights. It will be moving soon. So there will be a dedicated person to that soon as well. So we're going to move into some updates from Dr. Bhatt. My update is I will be at the Cambridge Health Tech Institute Sensor Summit 2022 tonight, actually. I'm going to fly out tonight, headed out to San Diego. It'll be a long 6-hour flight. I think I'm actually judging some submissions for some innovation contests when I'm doing that. But it's going to be great. We're going to have Eli Lilly, Best Buy, some presentations from the federal government and how they're looking at sensors. And it should be really good. So look for me in San Diego. Over to you, Dr. Bhatt.
Fantastic. Thank you, and happy Tuesday, everybody. As Jennifer heads to beautiful La Jolla, I am here in Boston, where there is yet again snow on the ground, which seems to happen often in February, March, and sometimes April, but let's not hope this is one of those years. We are excited to have some fabulous guests lined up over the next several weeks. You'll notice that we're going every other week now, just to keep a cadence for all of you who are wondering, where we've been. Exciting things that are coming up. In addition to the Sensor Summit, we have the American College of Cardiology annual meeting coming up. It is going to be live and in person in Washington, D.C. So to those of you who are wondering, should you be virtual or in person, you should be in person, see the cherry blossoms, and come meet us. It is time that we all come out again. So looking forward to that. There's going to be something called the Future Hub. We'll talk more about it as we get closer, but really full day opportunities to meet with one another who are interested in innovation, meet with companies who are interested, some pitch contests that will be coming with some great new technologies that will be judged by some delightful and animated judges that we have chosen this year, and just a really great opportunity to learn some very good science. So interested in hearing more from all of you about what you want to see there, and telling you more about it as we get closer. I will start with an introduction for Dr. Anand, who is joining us now. So Dr. Shikha Anand, MD, MPH. She did medical school at Albany Med. She was at Yale Medical School, for residency in pediatrics, and then Boston University for general academic practice, as well as health services research. She is double boarded in pediatrics and clinical informatics. So really exciting for those of us who are doing the digital health work to have people who are both clinicians who also have a deep understanding of clinical informatics in this field. She was previously at Walmart, at Aetna, at CVS, and most recently is the Chief Medical Officer of Withings. Just a little bit about Withings for those of you who may not know them as well. Withings is one of a globally renowned pioneers in connected health. Withings provides personal health data and insights to millions of people worldwide through their ecosystem of health tracking devices. And it is the producer of some of the top selling connected scales in the United States. We have been excited to work with Shikha over the past many months, excited to see where she's taking the company. And why don't we go ahead and bring her on?
Welcome, Dr. Anand.
Dr.
Thanks
Anand,
for
so nice
having
to
me.
have you.
I'm thrilled to be here.
Excellent.
Good to
Well,
see you
so
both.
I think today is the day. I'm looking at the audience who's watching us on social media, and we have a range of large companies, some of your old companies, entrepreneurs who are watching, but also a good number of female physicians out there. So maybe today would be a good day to start with just a little bit of background as to how you kind of came from pediatrics and clinical informatics, and then made that move over to CVS and Walmart and Aetna, and then a little bit about what your role is here as Chief Medical Officer at Withings.
Absolutely. And so I'll give you maybe a little longer version of my intro than I typically
Great.
would for a podcast like this. I think the top line is really that my career has meandered and really around this notion of consumer centricity in health. I'm trained as a pediatrician, and my clinical background is really with the urban underserved. And so I'm acutely aware of how much people's context drive their health decisions, and how much of health is influenced by that. So I did my pediatrics residency at Yale, as you said, and then came out and did a general academic pediatric fellowship. Really wanted to understand better research methods, and how to do really tight research analyses. I realized very quickly that I didn't have the temperament of a researcher. I lacked patience, which is important in research. And so came out as the pediatric director at the Whittier Street Health Center in Roxbury. So really focusing on clinical innovation on the ground, and getting my feet underneath me around clinical operations and how the finances of the clinical system work, but doing it in a context where public health and community are incredibly important. And so designed a few different innovations in that time period, most notably a fruit and vegetable prescription program that's now scaled nationally, and then a multidisciplinary obesity program that now has legs with the CDC. So really thinking about how we scale this type of on the ground innovation. And that led me into the next piece, which is really understanding quality improvement methods. So as I went to fundraise for the programs that I was leading, I realized that standard statistical methods actually don't work, because my faculty colleagues would tell me to cluster randomize. But if you're doing a program that includes farmers markets and communities and health centers, by the time you cluster randomize, you need like 150 sites, which is millions and millions of dollars that no one's going to give you until you have proof of concept. So you end up in an infinite loop. So for about the next 5 years, I was at the National Institute for Children's Health Quality, which was originally the pediatric and maternal child health spinoff of the Institute for Healthcare Improvement. So really running large scale quality improvement programs at the state, the local, the federal level, and understanding how those methods could be applied to adjust for the heterogeneity that we commonly see in public health type initiatives. I spent, as I said, 5 years there, and then was in line to be the CEO of the organization, and decided to do a search while the board vetted their candidates, and ended up working in industry at Walmart through this kind of surprising process for everyone, including myself and my family, and really went there to help start the Walmart Care Clinics, which is the predecessor to what's now Walmart.Health. Spent 2 years there. Really, my goal there was to redefine healthcare for the rural underserved and bring in that layer of consumer centricity for people who are often disempowered. And then have worked in a couple of stints in startups, and one at Aetna CVS, all with this goal of how we can use digital technologies, both on the provider and on the patient side, to enable consumer empowerment in health decision making, and enable providers to embrace that technology. Because I think right now, our systems don't really allow us as doctors to embrace that technology, right? It's impossible to manage information coming in from 12 different sources in a 15-minute visit. I think all of us who see patients know this acutely well. So then the question is, how do we create a system that brings that patient empowerment that everyone wants to the forefront, but also enables doctors to be the doctors that they want to in the context of all of this information?
There are so many things that I want to pick apart from that introduction. First of all, the food prescription service concept. Um, so incredibly important. I can't tell you the number of times that that has come up just in the past 2 weeks in thinking about when we want to do, and in my case, it's cardiovascular preventative services, right? Um,
Yeah.
how much food plays into that is amazing, and how little attention there is, partly because it is so challenging to get into the community and be able to do that kind of work. So I realize that's not necessarily what we're here for today, but I really love that. I also love this concept and the way you said it, consumer centricity to those who are disempowered. So you have this line from urban inner city, which was, in Roxbury, and then thinking about the more rural through the Walmart.Health or the Walmart Care Clinics as they started, ensuring that people get this. I guess one question just to start with, because you've done this successfully now a few times, is you are piloting, and for appropriate reasons, as you said, right? Cluster randomized is not going to work. You are piloting in these smaller at-risk areas. You are demonstrating you've gotten to scale every time. Can you talk a little bit about, and I know it's different each time and there are unique circumstances, but there must be some method to how you are that successful repeatedly in taking things that address social determinants and bring healthcare into the community and then bring it to scale, because many people get stuck on that step. So just, do you have any thoughts on that before we move forward? Then I know Jen has questions too.
Yeah, absolutely. So I think you might be overestimating my level of success. It sounds really nice in retrospect, but there's been a whole lot of failure along the way. So for those of you who are doing the work on the ground, I don't want to skip over that step. I went into quality improvement because I was failing using my statistical training to prove the concept of what I so much believed in. So I don't want to let that go. But I would say that the most important thing is beginning with scale in mind. So there are two pieces to that, right? Understanding the outcomes you're going to measure and how you're going to demonstrate success is really important. And typically, you really need a mix of measures, right? You need qualitative and quantitative measures. And you also need kind of leading and lagging measures, right? So you want to think about what's going to move really quickly, because if you only have 1 year of funding, focusing on decreasing MI risk is going to be really, really challenging to do if you're working in a young population, right? You're just not going to see a statistically significant difference unless your population is huge. So what can you move quickly? Maybe it's eating habits, maybe it's purchasing habits, right? So start to think about how you lay out that measure set so that you can have a kind of roadmap of outcomes, and you can say to your investors or to whomever you might need to scale, be it the CDC or any other body, that here are the steps. Right now, you'll see this change, and then we expect to see this change, and then we expect to see this change. But asking me for the third change in the first step actually isn't going to work. It's not physiologically possible, right? So I think that's one really important piece, and that expectation setting is so important. The number of times I've gotten in front of an investor for an early project and had them ask me for a JAMA article with proven health outcomes, I can't count. And it's not possible. And particularly if you have people who don't know the healthcare space well, you have to draw that line for them that this can't happen in 1 year, and no one can promise this to you credibly. So I'd say that's one piece. And then the other piece is designing your systems for scale. So how do you think about spread from the word go? If you're piloting a program in one place, what's the critical essence of the program that you need to replicate? And this is as much of an art as a science, So often people who are doing work on the ground make the mistake of saying you need to repeat every step in our 200-page playbook and replicate it at the next site. But the reality is, particularly if you're working in community health, it's impossible to use the same, at least in my view, it's impossible to use the same 200-page playbook in every community. There are different ethnic mixes, there are different community assets, there are a variety of different factors. So it's really, really difficult. So the idea is to say, what is the core that you think is working? And then how do you find another site that can replicate that core? And then what's the structure you need to put around that? And then how do sites start to learn from each other? Because your pilot site is not always your best site. If you do this
Great
really
point.
well, your 8th or 10th or 40th site is going to be your best site, and they're going to teach all the others how to do it better.
That's fantastic. I love that insight. Jen, questions from you?
Yeah, I work a lot in the startup community and really understanding the different stakeholders. And I'm also a doctor, and I still try to understand the stakeholders. You have a fascinating background that's really covered payer, tech startup, the CVS is the Walmart, which is consumer health, but also the sliding of just consumerism into consumer health. How are those different, and how do you think of them, and what are the pros and cons, I guess, now that you've seen behind the scenes of what their ability to do for healthcare is?
Yeah. So I guess I would divide the world, and there's so much expansion and so much bleed in this moment that the divisions are a bit artificial, because we see consumer-facing companies moving more deeply into the healthcare space and vice versa. But let's take a traditional approach and think about
you think they're going to just all blend together? Is that what you think we're at that level of inflection point?
I think they've already started to blend together.
Okay.
So I think we're actually past that critical inflection point. I'm not clear on what it means. I'll be perfectly blunt about that, because we've yet to see anyone cover the consumer as well as they cover the doctor. And I'll just use the doctor as kind of an umbrella term for the healthcare system.
What does that mean? Okay.
So let's take different examples, right? So if you take, Apple, incredibly successful company on the consumer side, their forays into health have been in fits and starts, right? Because what a consumer needs and what a health system needs are inherently incredibly different. And so, and then you can take it from, name your novel health system that's trying to be more consumer centric. You'll see the same kind of tension exist, or the converse tension exist, if you will. And so what I'd say is, right now, we're still in a place where the doctor, and again, the healthcare system is what I don't think it's us as people, but the doctor's needs are really different than the patient's needs. But when you boil the patient-provider relationship down to its core, that actually isn't the case. I mean, if right, we're all doctors on this platform right now, like the three of us that are talking. When you walk into an exam room, I don't feel that my needs are different than my patient's needs, right? We're both trying to get them to better health and understand their context and understand how to make good decisions with regards to that. However, when you think about what's designed for me, it's a billing system. You can put all the bells and whistles in the world on it.
I don't know if that was designed for me. It's designed for someone who hovers over me, but okay.
It's for me. Right? Okay.
Do I like that person? Do I not? We have a tense relationship too.
Totally agree. However, when the me is being thought about, the me is the billing me, not what I would consider the doctor me, right? Which is the one who's really trying to improve health. But if you take that, and then similarly on the patient side, a lot of what's given to them is, tools to help advocate or to kind of push me in a different direction or things like that. And I'm not saying patients don't need to advocate for themselves, but at its core, we sort of want to swim in the same direction, and the currents are pulling us apart when you think of any doctor and their patient, or at least that's how I view the world. And you guys can tell me after about how Pollyannish I am, even after all of these years in practice, but I still really deeply believe that, and that's still what drives me. So when you think about that, then you start to say, we're still in this moment where the consumer-facing businesses are pulling the patients to their consumer side, and the doctor-facing businesses are pulling the doctors to their side. We haven't yet gotten to the place where we're looking at the Venn diagram and thinking about how much interest patients and providers share, and try to build a system that really hits the center of that Venn. So hopefully that wasn't too esoteric.
No, that's fantastic. You know what I love is
we're geeking out a little, but yes.
No, but this is good. So when Jen started her introduction today, she was talking a little bit about the Sensor Summit, and I noticed that you mentioned Best Buy Health. And I was just thinking, if you think about the Verizons and the Best Buys out there, you think about the pharmaceutical companies, you think about the Walmart and CVS consumer facing in the pharmacy space, all of them now have innovation groups, innovation arms, digital health groups, starting to think about
big buys in healthcare.
Right. Like really thinking about where can they, and I don't even want to say play in the sandbox, because they're not there to play. They're there to reach out to those consumers and make health better. So I do like our Pollyanna concept of what we need to do is actually blur those lines a lot more in certain areas when it comes to the building of infrastructure for care delivery. I don't think there needs to be a blurred line. Now, are there going to be blurred lines when it comes to finances or programmatic or governance or other? Sure, operations, all those things are going to have their own distinct units. But I think when it comes to building infrastructure, you're exactly right, Dr. Anand. When we move in this direction, I think all these people working together and building that infrastructure together is essential. And it doesn't have to be just three different organizations who do it, right? You can have different models of this in many
Yeah.
different areas throughout the country and the globe, where people start doing it. And perhaps those groups can come forward with the core of what about our collaboration can be reproduced somewhere else, right? Going back to what you did, take what is that core of the collaboration, define it, and then share that with others. And I think that would be a wonderful direction to see things going in. And I'll maybe turn that a little bit towards Withings, because that's a lot of the kind of work you're doing there. And I know some people we're geeking out a lot, but this is great. But but as we are nearing the half hour, I suspect we'll go over a little if we can. But let's turn it a little bit towards Withings and talk a little bit about kind of that concept and now this company and where you're thinking of heading there.
Yeah, absolutely. So, Withings began with the first connected scale in 2009, right? So at our core, what we do is sell scales. That's not who we are anymore, but that's who we've been. And many people may know that we were acquired by Nokia. We did a brief stint with them. And then we were purchased back by our founder, Eric Carril, and have been independent again for about 3-ish years. And so with that, we've really doubled down on our focus on health and really health much more broadly. So first we had scales and then we had blood pressure cuffs. And now we're really trying to expand our suite of at-home devices. We have a sleep mat. We have a smart watch that tracks oxygen saturation, ECG, pulse, as well as steps. So, you can get a variety of different health metrics. And in January, we announced, it's not yet on market, a body scan, which is our new scale, which also includes a 6-lead ECG. It includes vascular age, which we've had in a prior version of the scale. And then it also includes essentially foot nerve activity. So it could be an early precursor to neuropathy, but really stimulation of the sweat glands in the feet to understand how the nerves are functioning in the feet. So when you start to think about that, and then we have more in our roadmap that I can't discuss publicly, but the idea is, how do we get a sense of holistically how people are at home? And how do we use that data to find inflection points of two types, really, right? One is, when is a moment to take action? So we know you run 5 miles every day, and then you go through 2 weeks where you completely stop running. Well, does that mean you're injured, that you might need some clinical assistance? What does it mean? How do we converse with our users to understand what that means, to have those actionable insights? I think that's really important. And then I think the converse is, how do we know when you've got a sentinel event, right? We've got ECG on a watch, and okay, so now you've got a first notification of AFib. How do we support you in that moment to make things better? So we can support you. Well, I guess I gave you 2 examples in which there was kind of a challenge, but what about, you haven't been running for a year and now January 1st comes around and you've decided it's new year, new me, and now you're running 5 miles a day from nothing, right? How do we support you? How do we help keep the momentum so you don't dry out on January 15th like everybody else does? And so I think there's a lot that we can do there. And so in terms of where we're going as a company, there are a few pieces. So one is a broader suite of measurements. And that is both de novo measurements, as I mentioned with the launch of Body Scan, but then also thinking about how we combine these signals,
Yes.
using machine learning to really understand early signals of things that might be bigger. We have we're an established company, so we have a fairly large user base. There's a lot that we can learn with our consumers there. And so I think we'll be expanding both the breadth and maybe the depth of our measures. And then it's really, how do we help people take action? So, as I mentioned, my background is first as an obesity researcher and having run obesity clinics, and a long time in health behavior change and motivational interviewing. And how do we really think about people's core purpose and their health context to that conversation about being a pediatrician and, for the urban underserved? How do we really think about thinking about people's context, thinking about their exact moment in time rather than a set of health metrics to help them get to whatever the next stage of health is, understanding that that is not only different things for the same person over the course of time, meaning you might be much more physically active in 1 month than the next, and the difference might be a move or a job change or the beginning of the year. But also that people are often in different stages of wellness with regards to different aspects of their health at the same time. And that's why that holistic measurement is important, right? So you might be in great shape with regards to your physical health, but horribly stressed, and your mental health is terrible. And so how do we think about that complexity together and really start to look at a whole person in the context of their environment to think about how we can make better health decisions as a society and how we can help individuals do that?
I love this concept. So, Jen, then there might be questions coming. I'll ask one, and then if there are any coming in, you can ask those. But I love this concept. A few questions, and I won't aim them at Withings because I know there's things that you probably can't talk about. But in general, with your experience, a few areas that I would love to see things go next, and I'm curious as to how you think we're going to get there. So, one is when we gather all this information, how much of it goes straight back to the patient? How do you organize it for them that it's not alarming but helpful? And where does their chronic care provider come into that picture without increasing administrative burden of kind of throwing things more at them? Is there, do you think that most systems like this, and maybe relevant to Gen Sensor Summit coming up too, does everybody need a closed loop platform that includes patient, maybe local caregivers, doctor, and I mean caregivers as a non-medical, and then maybe clinicians? Do we need a closed loop for these things? Does that have to be where this field is going for it to be effective? And then the second question is, are companies in general willing to work with clinicians to really look at what machine learning can do with all that ambient data and to publish that? Because when we don't publish it, people don't trust it, and clinicians don't really trust machine learning as much as they could if more of it was out there and published. So two separate questions, maybe first closed loop, and then a little bit about
Yep,
publishing in ML.
absolutely. So with regards to closed loop, absolutely, I think that's the ideal state, but I think it's incredibly unrealistic. You'd need a non-capitalist society to make that happen if you think about the variety of people that own pieces of health data. So the way in which I think about this is kind of that adage that with great power comes great responsibility, right? Like I probably completely misquoted that, but so I think we're giving patients more control, more power over their health. We're putting more data at their fingertips. For companies like mine, it's imperative that we do this in a way that's seamless, in an experience that's pleasing. So, giving them a table, I'll give an example. I don't think anyone does this, but were we to give them a table with every blood pressure they've ever had for the last 10 years, that would be very, very just irritating, right? So how do we contextualize the data? How do we make meaning of the data for people so that they can kind of take charge of their own health? Oh,
Yeah.
our cup.
Yeah, no, I use it. Okay, so everyone already knows that I've had COVID a few times. I'm in the ER. I treat COVID patients. It's ground zero. Boston has a lot of COVID patients. And I have been fascinated about the cardiac complications. And the VA just published one of the largest studies, 500,000 patients, because the VA is the largest healthcare system in the world. And we have the most massive EHR data. Anyway, so it's a nice cuff. The data is super interactive. It has me in the yellow category. So I looked that up. Not what the yellow category means, but like where did I come into the yellow category? And there's some data that COVID has been related with new bumps in blood pressure. So because I've been tracking it on this, and you guys make me nervous when you put me in the yellow category. I was like, well, maybe the anxiety is causing the yellow category. But it's beautiful. Possible. And I am having chest pain after my most recent stent. And you'll see from the data that's been published that any COVID across the board, mild COVID, didn't even know you had COVID, extreme COVID, bad COVID, 63% more likely to have a heart attack in these first 6 months that they were followed afterwards. Don't quote me on the 6 months, but at the time frame on the afterwards. And then 52% more likely to have a stroke. And I'm having this chest pain with exertion, and it's actually crazy hard to find an EKG as a doctor. It's hard to get an EKG. So I am interested in this. Sixthly, I have your Withings. Do you use this Withings scale? It tells me the weather too. It's fascinating. It says hello. Yeah. It tells me my birthday. Happy birthday, Jennifer. It's actually quite cute. But I would love to know my EKG readings, because the arrhythmia concern afterwards with the post-COVID.
So hold for a second there,
okay.
Because let's have this conversation out for a second.
I like this. Because it just beams. The data just beams.
You take your blood pressure, you're getting yellows now, right?
Yeah.
And then
yes, and I never got yellows before. I used to faint because I was so hypotensive.
So that happens, and then let's say you get an EKG from any company, right? And it tells you something is abnormal. Are we leaving you to now have patient agency to go to a doctor with that information? Or is it our responsibility as the innovators that the three of us are to somehow make that transition from you and your personal agency to a clinician who is your longitudinal clinician better? I don't know if it's our responsibility, but I throw that out as a challenge to the two of you. Should your doctor should not receive all of that information every time you record it. Let me just put that out there. I think we're not ready for that yet. But where do we make this transition make sense? And, when do we trust it to what degree, right? And so I just discuss amongst yourselves. I'm curious, what comes next? What comes next?
In my practice, I'm going so fast that everyone's going so fast. I'm in the ER. So I don't have time to vet outside data. So as a practice, I'll just be upfront. I'm like, I don't have time to vet outside data. So I look at it skeptically. But when patients do come in with chest pain and reports of shortness of breath and arrhythmia, and they show me, and we can dig into their Apple Watch and look at trends, that's useful. Overall in my head, I'm still like, I don't know how vetted the Apple Watch data is. Was there a usability issue? How good is the data? But that really helps. And in terms of describing a story, it's just really hard for people to remember what happened over the last 3 to 6 weeks in terms of telling the story of the progression of shortness of brain and chest pain. So that really helps them line up their stories and helps me along as well. I think if I were in primary care, I'd make some exceptions for data that I did or did not have time to accept and consume. What I would love to hear from Shikha in particular is we're seeing, digital health, and what does a feasibility usability trial look like? What is the enough data to build an algorithm? What is enough data to validate an algorithm? And how do you actually run that with scientific clinical rigor in a safe space in a clinical setting? The people who are coming up with these ideas don't have the classic training that like Big Pharma has and understanding the powering of a study, the safety and protection mechanism, the checkpoints. I think to Dr. Bhatt's point of where are we going as a society, and there's just not enough clinicians to consume and vet data and process it. So I think Dr. Anand, you're saying, it's just not feasible. So we are just going to have to start living with more liability that we're kind of placing on the patient. But also, how do we make that transition in terms of clinical trials that we're bringing into the hospital and running on patients and ensuring that those have the safety factors built in? Because we're not just going to drop, in a clinical trial, you should have some safety mechanisms. Then you see some things and then you're like, okay, this benefit comes with this risk. We are all aware of the benefits and risk. We signed off on it. But before that, we're at the phase of what does the clinical trial look like?
Okay, so there's
that was a lot. I've been thinking about this a lot.
Should she take question 1 or 15 first? Yeah,
exactly. So I want to go back to responsibility for 1 second, then Jen, okay. I'll come back to your question. So in the broader context, I think in terms of responsibility, I think it's people's responsibility to take care of their health. But to the extent that we are surfacing information or data to people, we need to be responsible stewards of that information. So concretely, what I mean by that is, in my role in the company I work at or in industry, I think it is very much our role to tell people when they should see someone, right? Like, hey, actually, this data is kind of worrisome. So maybe we leave you in yellow, and it sounds like, Jen, maybe we need to do a better job of telling you what yellow means, but we can take that part offline, right? But so one, we need to tell you what your data means at a high level, right? Obviously, you have some context as to what it means, but if you didn't, we should be telling you what is yellow and when is yellow red, right? I push back against color systems, but they are very easy to talk about. So right, when does yellow go to red? And then when it's red, what kind of red are we talking about? Are we talking about 911 red? Are we talking about call your PCP red?
Right.
Are we talking about, hey, take a deep breath and take it in another 20 minutes, like a high blood pressure red, right? Which still could be red, right? And how do we sort of get people to understand that one data point without any other factors can't in its own right be red? I mean, that's for almost anything. There are some things, but mostly they're only clinically available, right? But even if you had a pulse ox on our watch of 70, right, which probably would be red if you were a healthy person and you just acutely dropped, particularly in the context of COVID, I would want to check it again before I'd call it actual red, right? So in everything, there's an algorithm for what are the next steps. And so I think it's our responsibility to contextualize the data, to walk the person through the next steps and give them a series of responsible options, right? So in our context, that means, hey, if you have a great doctor that you trust that's going to call you back, call them, right? If you don't, here, we can link you to telemedicine or we can find you another way out. But if you've got a great relationship, use your great relationship. If you don't have a great relationship, it's probably not a good idea to call the receptionist at a random doctor's office and wait 3 months for a physical. If we really think you're in the red zone, let's find another path for you. And always, let's try not to make it the ER, because that's usually not the most cost-effective way to manage digital health data.
I love the way that you
patient-centered.
I love the way that you put that, though, right? With those who have a solid relationship with a chronic caregiver, this is probably a time to reach out. For those who don't, because a lot of, and I won't say that only younger people use technology, because my parents were great with it. Older people use technology well, but the younger people, we do know just from numbers, use technology more, have primary cares less. That's just where we fall right now. Don't want them using the ER. So I like this idea. And I know we're not getting to closed loop, but I just want to say you're headed a little bit towards at least a platform of somebody who will circle back with some more expertise if you're not an ER physician who's using the blood pressure cuff like Dr. Joe, and help you make sense of it. So I love that sense of responsibility too, as a potential for any companies who are out there and watching and thinking about sensors or monitors. And are there ways that we can connect either directly with chronic caregivers, or at least with a system that can provide some clinical support, especially now that we have so much virtual care available. So I think that is really important. The one other thing that I was just thinking about is, as we bring some of this data in, it would be great to see what people's reactions to these trends are. Not only what is the data that we gather from the various companies who are watching, but or at your Sensor Summit, not just what data do we gather, but how do humans, what is that behavioral reaction to the data we give? I feel like that's an area that really could be studied more in digital health, and may give us insights into how to better engage people in their own health. So I feel like there's a lot of data out there that people study and use and apply ML to the data, but not to the reaction between patient and data. And I know that's harder information to get. But that might be an interesting area to go in the future, especially with your behavioral health background. I'll just throw it out there.
Or how to give them data in a meaningful way that is delightful. Sorry, that's
the secret sauce, right?
That's my pitch. It's always got to be delivered well.
Jen wants the color not to be yellow, but a gentle peach, and then everything would be okay. No.
Yeah, exactly. So Jen,
I like red, yellow, green, because it's in the U.S. At least our stoplights are based on that. I don't drive anymore because Boston drives me insane. It causes so much anxiety. But everyone knows stop on red, go on green. Yellow's kind of in between.
No, I mean, it's worked
in Boston. It's accelerate. No, okay.
Going back to the original thought too about food prescription and where you started, Shikha,
Yeah.
wouldn't it be great if we did digital health prescription? I know a lot of places are working on that now,
I
but
absolutely think we need that. Yeah.
I love the idea of prescribing something for my patient, saying, in this situation, this is a useful tool for you. And in this situation, please do not use this tool because it is not relevant. It will only cause anxiety. You're not going to get the right thing. You sat at 70. My patient population sats at 70 sometimes, right? So O2 sats blaring at them all day does not make any sense. And so I like the idea of also moving towards digital health prescription. I know a lot of people are working on it, but for those of you who are not or have not looked into it, I think that's an area that everyone should focus as well.
So I have, oh, sorry.
No, I was going to say please to you because we're at 12:44. We shouldn't take too much more of your time, but any other closing or forward-looking thoughts from you, Dr. Anand?
So I'd say, well, one, I just want to come back to what Jen asked about clinical trials for a moment.
Yes.
And I just, really what I'd say at the top line about that is we have this notion that trials need to occur in the hospital. And I vehemently object to that hypothesis.
Ooh.
I used to be a hospital researcher and I don't agree. So I don't think it's how do we bring it back to the hospital. I think it's how do we bring the expertise out into the real world? Because in fact, not much of life occurs in the ivory tower. So let's bring the research to where the people are. So I'll kind of stand on a soapbox as a part of my outgoing comments on that piece. And then in terms of the fruit and vegetable prescription program, when I created the program, I was ambivalent about it, and I continue to be ambivalent about it. And the idea of the program, I'm incredibly passionate about. The part that I'm ambivalent about is we're really using a doctor's prescription as a proxy for anything that's health improving. And I think that that's actually a big challenge in the system. I don't believe that I am a doctor. I don't believe that doctors should be the controllers or the gatekeepers of health. I think that people should be the gatekeepers of health. And by making something like a digital health prescription, you're once again putting the power in my hands as a physician, not putting it in the hands of the person. So I think it's going to be a necessary step because that's the way that money flows. And you can't get away from the way that
Jen, did you hear this? So Shikha's also my friend, right? She just threw me under the bus. She said, Dr. Bhatt, you are doing the opposite of patient agency, which you say you love. No, I love this conversation. It is great.
I didn't hear it that way. See,
no, but this is,
I didn't hear it that way.
No, but this is a great ethical debate of like where does agency for health lie and where does responsibility lie? I don't think we won't get through it today, but I think it's a great continued conversation, even for our audience to have with one another, right? Is how do you empower people without taking away their power? And I think that's a great question. Sorry, keep going, Shikha. I just had to call that out there.
So I was not throwing you under the bus. And
no,
thank
I'm
you,
joking.
Jen, for backing me on carrying it in the
either.
right way.
I heard it's very nuanced, and there's lots of nuances.
There is lots of nuance, but it is really, I mean, I do honestly believe that all of us as doctors were trained to be somewhat patriarchal, no matter how much we think that that's not who we are in the rest of our lives, or that's what we were trained to do. I think that's what we were trained to do. And so at some point we have to own that, and we have to come to terms with it. And we have to say, yeah, research actually occurs in people's lives. Yeah, health actually occurs in people's lives. It doesn't, not everything that we observe is better quality. And I think that's, to me, that's the core of the digital health debate, right? Is how are we as a community of professionals going to accept this? It's coming. It's here. We can like it or we cannot like it. We can embrace it, and we can think about patient data being just as valuable as kind of doctor data. Or we can take it really differently, right? And so, and look, there are places where the data quality is an issue. So the question for someone like me is, how do we create the right scientific validity for our data to give doctors comfort in what they're seeing? So, is our 6-lead ECG the same as a 6-lead ECG? We don't usually do 6-lead ECG, so that's one inherent problem, right? Everything you can deliver at home isn't often what you can deliver in the clinical setting. So what are those gaps? But what can be accomplished reliably with what's done at home? And how do we kind of lay that out in front of doctors so they can use them in the right way for decision making? Because there's going to be information missing on a 6-lead ECG, as an example, that exists on a 12-lead ECG. That isn't relevant for all diagnoses or all use cases. So in some cases, 6 is great. In other cases, 12 is necessary. How do we start to put together that data to make doctors feel responsible? But right now, as a medical community, we're still in the place where we're like, 12 is better and we bill for it. So we're just going to do 12.
I love
would
this
push back and say
conversation.
that's old. That's
No,
old
I
thinking.
love this
I
conversation.
would say
So
I've been having chest pain for 3 weeks, and it was very, very hard to convince my provider to get an EKG on me. So I would say that 6 lead is better if you can't get a 12 lead, or if it takes 3 weeks of chest pain, which in an ER world, that's insane.
Yeah.
so I'm
I think that's
gonna
insane in
throw
general.
a little structure around this for our audience.
Okay, thank you. Thank you,
Just a little-
structure, Dr. Bhatt.
just a little structure. So data, I love when we come back to data standards, right? Like we need good data standards. People need to understand what they are, and there are people who are out there writing about this. I will direct people to the Digital Medicine Society, DIME. I will direct people to the Consumer Technology Association. We had a great webinar last week that you can look up that was the American College of Cardiology, Consumer Technology Association, and DIME together, talking about kind of bias in data, just important to kind of think about. However, you will also see from that, or you can look it up independently, we do have guidance on consumer technology put out by the American College of Cardiology and the Consumer Technology Association. So if you just look that up, you'll see we have kind of guidance on thinking about consumer health tech. That comes with some cardiovascular background if we're really going to have that EKG conversation. There's also some great digital health standards that are out there that are published by a variety of member organizations in the medical and tech space. So there's definitely places for people to go for guidance if you're looking for that, either as a clinician, as an interested individual and patient kind of consumer of health, or a company who's starting to get into this field and wants to look. So there's definitely some structured information out there, and hopefully all of us will together come out with more in the next 12 to 18 months. This is always such a great discussion, Dr. Shikha Anand. Like being with you, we could do this for hours. We'll let our audiences finish up their lunches and get back to work. But thank you again to you for spending this time with us. And I will leave it to Jen and our audience to say the final thank yous and goodbyes.
I really appreciate Dr. Anand for coming on our show, giving us so much insight in the changing world of digital health, clinical trials, how we deliver health, how we think about health, how we think about agency. Really appreciate that. Dr. Bhatt, always a beautiful host that frames things so well and brings me back on track. Thank you to our audience. It was great having you. And be sure to look for our show. It's recorded after the fact, so you can go to YouTube, Facebook, and LinkedIn to see that. And we'll be a little bit better with introducing when our next show is. Thank you, Dr. Anand. Thank you, Dr. Bhatt. Thank you to our audience. Bye-bye.
Thank you. It was a pleasure.
Take care.